Research Podcast, VIR. I'm your host, Dr. Rand, founder of Diverse Research Now. And today you will hear the voice of a dear friend of mine, Dr. Eugene Manley Jr. Dr. Manley is a scientist, health equity advocate, and public speaker dedicated to improving outcomes of underserved communities across the cancer care continuum. He is the founder and CEO of the STEM and Cancer Health Equity Foundation, also known as SHEC Foundation, which is a nonprofit advancing two critical missions in increasing diversity across STEM fields and improving outcomes for underserved populations navigating cancer care. He is passionate about sharing his lived experience with medical racism, advocating for diversity in lung cancer research, and his work with his foundation. And I'm just super excited to talk with him today. So let's get started. How are you doing today, Eugene?
I'm good. How are you? I'm so happy to be here and happy that you invited me on the show. So I hope we can make it entertaining and informative for your audience.
Eugene, now you know every time we talk, we have such a great conversation. We get into it. So yes, this is going to be interesting and we're going to just be open and transparent about the things, all the things, okay?
Yeah.
So first, before we get into all of it though, I want to ask you to share a little bit more about yourself with us and why you do the work you do.
All right. So we try to frame set or level set by training a mechanical engineer, biomedical engineer, and a cell and molecular biologist. That's the professional me. But the person where I came from is inner city Detroit, first gen, grew up poor, and really didn't see many paths out of Detroit. You know, I saw a lot of crime. I grew up through the crack pandemic. I saw a lot of, substance abuse. And, and it was really, really hard. Very few people got out of my neighborhood. Mm-hmm. But I grew up as a chronic asthmatic and was always in the hospital. And I sort of got an appreciation for understanding the body and physiology. And eventually I ended up going to college and doing the engineering degrees and then getting into the biology. But I really, really just took that lived experience and just saw, my family navigating care, being poor, and just how they got treated in the healthcare system. Mm-hmm. And then as I went through academia, we had a lot of programs at the time that wanted diverse scholars, but they really didn't help you grow, get grants written, advise you on the grants. And so your career stalled, and not necessarily because of a skill, but because of lack of institutional support.
Right.
And then as you transition into professional spaces, you still see a lot of patients that don't get information and resources. And I just took a lot of that stuff and said, how can I make an impact for people? So that's sort of how I developed the nonprofit. It was just seeing what my family dealt with. And so we do infographics, and just understanding how many minority patients don't get information about trials, testing. So how can we address that? And then trying to empower and, enlighten kids at early ages about the careers that they can go into. Because often when you're first gen, you just don't get any of this information at all.
You don't. I love the work that you're doing. So needed in our communities. Share with me about some of the work that you have been doing. When did you guys get started? And what kind of impact have you seen from your work?
We started in August of 2023.
Okay.
So we're relatively brand new. Mm-hmm. And of course, the first half a year was nothing because you're just trying to infrastructure, website, accounting, trying to set up your system to get and identify grants. And you would think even with the background in development, it would be no.
Yeah.
It still takes a lot just to even get the bare bones in place where you can start trying to do work. But some of the things we do are we really working on increasing health literacy. A lot of times, my family will be, well, what's this mean? And what does term mean? Or you get a report from a doctor and, just read the my chart. Well, one, they don't have a computer at home. Two, if what you need to do is on page 5, they're not going to get there because they're going to see a whole bunch of medical jargon. So you need to take the time to explain it.
Yep.
So we started creating infographics to try to break down medical terminology and also cancer terminology and then different cancers and a disparity with those cancers. So We're slowly rolling those out on the website now. So that started happening about maybe 6-7 months ago. So we just started finally getting the infographics out. The other thing we do our annual Lung Cancer Health Equity Conference. This year we now call it the Lung Cancer Solutions Conference. This is one of the things I'm very proud about because my training is in lung cancer and I worked with some lung orgs, but patients started reaching out, specifically Black and Hispanics, and they didn't see any information that reflected their lived experience. They felt invisible. They didn't get the same access to care. And so I said, well, in my head, I was just percolating thoughts, and then I ran into some people at a disparities meeting and said, well, have we ever really developed an event just for underserved patients with lung cancer so we can build the information and resources? That's in essence how the summit started. And we went from 42 people to about 112 last year. And so we have our third one that is going to be the 24th and 25th of this month in October in Chicago. So, and what's really unique about it is that we bring together patients, caregivers, survivors to learn more about the disease. And we bring together researchers, clinicians, payers, et cetera, to learn what other people have done to do solutions, not just talk about the problem, but solutions that have been done that reduce disparities, reduce inequities, and or improve outcomes. And by having people in the same space, we hope to do two things. One, reduce those silos between patients and providers and other stakeholders, but two, also let them know who is actually working on their behalf, who they may be able to talk to or connect in their city or refer a friend that's in another place, because that's what they often don't know. And so we're just really driven by that work because it's just such a major need. And then as a result of this, we started a 2 lung cancer webinar series.
Awesome. So yes, I want to talk about that major need because I definitely, before we talk, wanted to look up some of the statistics in lung cancer. And it is still globally one of the most common and deadliest cancers. And I did see that in 2020, there's about 2.2 million new cancer cases, lung cancer cases. And then do you know the breakdown of like, is it disproportionately affecting Black and Brown communities like so many other conditions? Do you know that?
It used to be a very wide gap and there were so many more Black disparities. Though with more people doing screenings, the gap has closed. It is not completely closed, but it is closing.
That's a good.
Yes, that's the positive. But the downside is still people are getting diagnosed late. They aren't getting biomarker testing. They aren't getting clinical trials. They aren't getting all the biomarkers they are entitled to. And then there's stigma as well.
Yep. It's the same problem across the board, Eugene, like late diagnoses, not being asked to be a part of clinical trials, not having access to care. I mean, really, it's across the board.
And the challenge, the other thing with lung is that it's the leading cause of cancer death in the US and worldwide, but it still gets significantly less funding than breast, colon, and prostate.
Okay.
And they have biomarker tests that they can use to detect those diseases. Lung cancer has lung cancer screening. So screening means you go through low dose, CT. It's about a 5-minute scan, but it's still predicated on a 20-year pack history of smoking or having quit within the last 10 to 15 years. So the biggest thing with lung cancer screening is you have to have some kind of smoking history. Now, you can include other risk factors, but many places don't because that would be inclusive, but it's also a lot harder to do that. Like you could include things like vaping, cigars, radon. These are other risks, but you have to write that in your protocol from the beginning. And a lot of places are not going to want to go and do the extra work.
So we're not seeing protocols like that. It's
not readily. Nope.
Okay. So it's just focused in on like cigarette smoking.
Yep. Those are the guidelines. And if people only stick to that, we still only, depending on the study, maybe only 7% of eligible people are getting screened or 20. It just depends on which study you look at. But either way, the screening rate is still way lower than it needs to be because we do know for high-risk populations, those with the history of smoking, you can detect it early. And then if you can have better survivorship and generally lower healthcare costs.
And when you say early, how early? Because I do Is it true that lung cancer is predominantly seen or at least diagnosed in older adults, like 65 and up? So
Yeah,
how soon and how early are we should be if we're a smoker? I feel like, okay, if
yep.
you know you have been a smoker your whole life or how a long time, how early should you be getting screened?
Well, generally the screening guidelines say, I believe you have to be 40 to 60
Okay.
and a 20 pack year smoking history. So what that means is a pack year, which is the hardest thing people to understand, means you smoke a pack a day a year. So a 20 pack year history means a pack a day for 20 years, or 2 packs a day for 10 years, or 4 packs a day for 5 years. So those are all the same relative amount of exposure. So that's what a pack year is. Now, of course, when you're dealing with people from the hood,
Uh-huh.
they may not necessarily say they have a history of smoking. So you may have to work with them to figure out what terminology will actually let you know what are they smoking and what frequency. So you have to, so that's not in the guidelines, but you have to understand when you're dealing with community, how do they communicate and how do
Yeah.
you get the questions out of them?
So
So
important.
that's what the guidelines say. If they do it, that's what they will do. They will do no more than that. So now that's where we catch most of it. And often, though, it's still caught third and stage 3, stage 4, as opposed to others. But if you do screening, you might be able to catch it early. And then typically for screening, you have to come back for a screen at least once a year, but they can see if there's a nodule or if it's stable, if it's grown, because they don't want to necessarily go in if it's stable unless it grows. It just, so you use screening to monitor, also see if there's nodules.
Mm-hmm. Mm-hmm. And so we also, one of the things is that have higher rates than women. Is that true?
That is generally true, yes.
Okay. And
And
then,
in Black men in particular, we still get, the Black people in general, we still get diagnosed generally at younger ages, but more advanced disease.
mm-hmm.
But also, what doesn't go into guidelines is menthol and flavored cigarettes.
Mm-hmm.
And, those have been heavily marketed to inner city and Black communities.
Yep.
And so what happens is if someone's inhales a menthol flavored cigarette, menthol is very cooling. So if you inhale menthol,
Mm-hmm.
it will cool the lungs and mask the searing heat from the tobacco. So especially if your first experience is with a mentholated cigarette,
Mm-hmm.
they go, oh, this is great. Because then if you go to a regular, you're like, and then you think you're on fire because it's so singeing. But the
Wow.
menthol actually cools. So it made people think it's better. And the other thing is when you add menthol, which is cooling, and they usually add those additives that are sweet, when you add soothing and sweet on top of something that's addictive, that makes it that much harder to break.
Wow. I didn't know that.
Yep.
So, how much is, in your opinion, because once someone, so after the screening, right? After the screening, and say the screening indicated that they're at risk or they should go get further testing, or, what are the steps to that? Like, what is the steps? Like, what is next after screening?
So
And,
typically,
go
yep.
ahead.
Yeah, so typically, if after screening, if you're off, the clinic has usually a nurse or patient navigator, they would then set you up for doing shared decision making. I believe that's shared decision making. So you get to sort of have some input. It doesn't always work that way, but you get to have some input. But then you would do further tests, whether it's then a biopsy. Typically, it's a biopsy. They maybe or do some kind of imaging, but they would do that to
Okay.
confirm if it is not
Right.
is or isn't lung cancer. Then if they have to do the pathology, and they have to wait for the pathology to determine what course of treatment to take. And that can be the most nerve-wracking part because what happens, unfortunately, is a lot of people still only get offered chemo and radiation. Especially if you are poor, they don't offer you the other things that are available. So you have to know that there are about at least 11 biomarkers for lung cancer that you can test in tumors. Unfortunately, most people only get 1 to 3 biomarker tests. So if you don't even get all your biomarkers tested, you are at risk of having a disease that could be treated, but because you don't know which therapy you can use, you may not even get the therapy you need, and then it's going to end up being metastatic and worse off. So people don't even get offered all the testing that's available because of cost. But those are big gaps in care.
Okay. Oh my goodness, this is a lot. So, How do you advocate for those other biomarker tests? If your doctor doesn't want to do that, how do you advocate for more?
That's the hardest part. You probably need to link up with an advocacy organization or know someone that's already in the research space that can be your proxy and advocate for you. Because typically, if you don't have someone that can advocate, then what often happens, we'll see people with misdiagnosis, they get diagnosed as cough, or you're too young to get lung cancer, or you'll get ignored, and then you're fighting an uphill battle just to get screened. And if you aren't in the age bracket, they do not want to screen you. And so you really, really have to fight. But you also have to know if you have a diagnosis that you should ask for comprehensive biomarker testing or next gen sequence. You should ask for it because it is your life in your hands. Don't let a doctor just say, oh no, well this is no, let me know what type it is and if there's a treatment available. And then we go from there. But sometimes they don't get that option. So we really have to try to get all your biomarkers if possible and really, really push for it because there might be a therapy. And don't ever just get chemo and radiation. That was stuff they did in the 80s and 90s before we had this growth in biomarker identification and then targeted therapies, which really started around 2003, 2005-ish.
Okay. So at this time, like if you do get a diagnosis of lung cancer, would this be a good time to think about research, being involved in research? I'm wondering what's going on in lung cancer research right now. At what stages is most of the like protocols recruiting for? What stages of lung cancer? What is being looked at in lung cancer research right now, like for therapies?
Right now, we're big in this immunotherapy phase. Everyone is doing the immunotherapy. They just did some stuff showing EGFR. I was just at World Lung and oh my God, I just drew a blank. They did, oh my God, I feel so bad. They did a study and they showed a new possible standard of care that had not been seen. So I think it was a drug plus chemo. And I think the sequence in which you give it will dictate how they respond, but I really just cannot remember it right off the top of my head. As far as stages, it just depends on what drugs are out there. Some are phase 1, some phase 2, some phase 3. Typically, if you're late stage, you don't really get, like, if you're like stage 4, it's really not many of the traditional therapies, unless you have a biomarker, then they might attempt to treat it. But so research is pretty broad. We have a lot of stuff in the pipeline. We have some indications that work, some don't work. And then, unfortunately, when you're on a targeted therapy, the biggest challenge or concern is resistance to the therapy. Because typically, cancer can develop a mutation to a therapy, then you have another mutation. Then do you have another line of treatment for that next mutation? And then if you do, you can treat that. Then that may buy more time. But then you have a third mutation. And then cancer is always chasing ways to escape. And so it always becomes a play. Are you going to be stable or is it going to become resistant? And then there's another therapy, then it costs more money and then it costs more money. And so it can be quite challenging on people's finances to deal with lung cancer.
Yeah, I can imagine. Tell me about how much this system, because it just sounds like, of course, there's these systematic issues. These are systematic issues, right? People not getting the care that they need, again, across the board. It's a systematic problem. And a part of that systematic problem is like medical racism. And I know that's something that is dear to you because you had some lived experiences. Tell me about how medical racism kind of falls in here.
So we'll do it a couple ways. My mother was in the hospital a lot before she passed away, and I wasn't there, but you would just hear how the doctors would talk to her, or the nurses would just talk to her or ignore her and say, well, you can't get this. And it was just, they just treated her like she was subhuman. Like, it doesn't matter what income, you can still treat people with respect if you want to.
Right.
And then how this ties into me is that, I fractured my ankle earlier this year, had reconstructive surgery on my foot.
Wow.
Really not fun, I will say that much at all.
Doesn't sound fun.
I lost the first 5 months of this year in a lot of pain. And after surgery, I was non-weight bearing for basically the first 6 to 8 weeks. Even though I have a background in engineering and orthopedic biomechanics, and I've done many years of jujitsu,
Yeah.
and me and the surgeon had a comprehensive treatment plan.
Uh-huh.
You can have the best plan in the world, which we thought. Then the hospital staff can still decide, oh, this one's poor black and on Medicaid and clearly don't know how to read records, so we're going to just lie. So they had horrible bedside manner at Mount Sinai, Queens. The physical therapist that came in to do my skilled nursing assessment was so rude, dismissive. I said, I'm non-weight bearing. No, you have to use this scooter. And then I'm like, this walker. Now, mind you, I'm 300 pounds. I'm non-weight bearing. I'm drugged up. I've just had surgery less than 48 hours before. I've had a left ACL reconstruction and I have flat foot on the left foot. But you want me to hop on that one left leg and try to keep this leg that I just had surgery on dangling and have blood rush to this foot while I'm on opioids? What in the right mind makes sense? And then I found out 3 weeks later, when I finally was sort of lucid enough to read my records, that she lied in my medical records and wrote, patient has no pain and can ambulate. One of the nurses, the second evening, which was a Saturday evening, tried to give me a discharge notice at 6:30 p.m. and said, well, you'll be discharged tomorrow. And if you want to appeal, you can call one of these numbers. Now, there were 3 different columns. No number was circled. And I said, I'm not signing this because I've not even seen the surgeon yet because we got me out of surgery like Thursday night at like 9:30 p.m. So there was no way I was going to see the surgeon. I'm like, I'm not signing this. And I'm not talking to any of y'all unless I talk to the surgeon. But then they still filled out and said, patient refused to sign. And then put the signature, put self and the date. And I'm like, I didn't sign this. And then they had it back time, though, for 9:30 a.m. that Saturday, even though I didn't get that to 6:30 p.m. Right. Now, with insurance, you have to let them know by noon the next day if you're going to appeal. Now, mind you, it's a Saturday evening. There's no way you can appeal to insurance on a Sunday because it's a Sunday. And then the hospitalist on that Monday decided to ask about my ability to pay for skilled nursing, which is not her job at all, because that was not her function. Her job was to help navigate care, but really they decided to take over the care because that was a service I had to be admitted to because ortho apparently doesn't have direct admitting privileges. So that's where the problem started. So they kept the surgeon from seeing the records. He even tried to get another appointment with PT to have them redo the assessment, and they ignored him for 5 days until he finally complained. So at this point, I don't know what's going on in the record. Yeah. And then he finally gets them, and then I did everything right, and this is this, and blah, blah, blah. Wrong altogether, just belligerent, and he was not a happy doctor. He was pretty mad at them, but because of them and lying in my medical records, that prevented me from getting skilled nursing placement. And even though he did a peer-to-peer with insurance, the insurance person on the phone couldn't even believe this hospital was doing all this to me. But because OT and PT said patient can ambulate and PT said has no pain, he could not approve it, even though he wanted to. Okay. So none of this was me and none of this was the surgeon. He was advocating, right. But they decided to ignore him and ignore me. And then they still ignore my lived experience, my housing situation. And then on discharge, patient can go home and use the walker, the scooter, and go to the store, which is not true. And they just completely disregarded my whole safety and well-being. And that ended up falling the next day because I still had to try to go to the pharmacy to try to get a blood thinner. Because unfortunately, when you're on Medicaid, they, at least in New York, they don't deliver medications. You have to go get them. And so, yeah, it was. Yeah. And then even on discharge, they wrote it, patient has a caregiver. Like the whole reason we tried to put me in skilled nursing because I don't have a caregiver. I have no family here. My friends all work. And it was not my intent to be home because me and the surgeon had an agreement that the hospital staff collectively decided to interfere. Yeah. So my thing is I now know how Medicaid works and I never needed that lesson. But I want people to know if you ever go on a procedure, have a medical proxy that can go in person and read records. I had a proxy, but they were in Florida. Okay. But the hospital said, if you can say the date, the day, the time, whatever, they think you're sound. I was clearly not of sound mind. You have to know hospital leadership who you can write your letters to, certified letters to complain, know your Office of Professional Discipline to write complaints about specifically physical therapists that lie, know that you can file complaints with the Joint Commission on Hospital Accreditation. So document everything and make sure you can print every single page and see where they lied. Like only read this stuff after the fact. But because of their lying, I ended up stuck at home 3 weeks with no aid services at all. So I'm stuck non-weight bearing, trying to deal with a lot of pain and anesthesia. It was the most disgusting thing. And I would never, ever set foot in that hospital again.
You know what, Eugene, I'm so sorry you went through that, but your story, I think, and it's really sad, is probably more common than we think. And it's super sad. We have to do something about it. I tell people all the time, like, the hospital you go to definitely matters. Like,
Yes.
the where you're getting care definitely matters. So do your research. Know what's going on in that hospital before you decide to go there.
Yep.
And also, something else that matters is your support system. Oh man, I'm learning this so
Yes.
much with doing events in the community, even with my brain health events and Alzheimer's disease. A lot of times with the research studies and with that type of care, you need support. You need a caregiver. You need someone that's caring for you, right? A lot of people don't have that. A
Yes.
lot of people
Yep.
don't have that. So that's why, like with Diverse Research now, we did create a program called the Study Buddy program where we're hoping to like do a little bit of stepping
Yes.
in. That program is really not for caregiving, but
Yes.
at least we could maybe assign an advocate to them to
Yes.
help in some way and be there on their behalf because you needed someone there with you.
Yes.
You needed an advocate, someone there with you while you were going through this.
Yep. And so I learned all these things to file, what to do. I learned a whole lot that I never
Yeah,
thought I needed to experience. And you're sitting there, you're a PhD, you know this stuff, and they just completely dismissed you like you were subhuman. They only saw me on the bed as Black 48-year-old Medicaid patient.
right.
So that they said, oh well, we don't care. So if you have your healthcare, actually treat all people with dignity and respect, or treat you like they would treat their family, we have so much better outcomes. But really, we don't have a workforce that really cares. That's to be honest.
Yeah, yeah.
Not a lot of people care. And just think, if this happened to me, who knows how to navigate, who's on Medicaid, what's
Right.
happening to the people who aren't as educated, who don't have family members, who don't know how to read records, and you get pushed out the
Exactly.
hospital, you end up getting readmission. You don't even know why you've gotten pushed out. And you don't know you can appeal or fight. And so that's why the story is so important. But so many other Black patients in the hospital get ignored or
Yeah.
told they don't have pain. And clearly
Oh,
I had pain. I couldn't believe she wrote that. I was like, you cannot say I have no pain again when I'm getting Percocets every 4 to 6 hours
mm.
for like about a month and a half almost.
So
You
what
cannot say.
happened? Did anything happen to her or what is it, this is still open?
And I wrote letters to the hospital with my title as doctor. And then when I called patient relations twice, they never called me back. So I put that in a letter. The only time they called me was after I wrote that certified letter. Well, we're sorry, we're going to do an investigation. And then I got a letter saying that, but they addressed it as Mr. Manley. And then I got a letter from the chief medical officer saying, we looked and reviewed records. We did everything according to what I was like. You did absolutely nothing at all. And the only thing they wrote, we gave you a scooter on the last day, and we don't normally do that. I'm like, you act like give me a scooter on day 8 when you treated me like subhuman as you're doing some charity work. Like
Right.
if you had listened to me and the doctor and got me in skilled nursing like he asked, we wouldn't have had this issue. And if they had sent me home early, I would have died because I ended up spiking a fever in the hospital and having liver numbers all out of whack because the first blood thinner was just killing me. It was throwing everything out of whack. So if they had sent me home with the first, I would have been dead anyway. So I tell people, make sure you have a proxy that can go in the hospital and read your records in real time so they don't do this stuff. And now I know who in my networking when I have to get the other nip. I know who's going to be in that hospital, and I know I will never, ever, ever set foot in that hospital again. And this is wrong. So many patients go through this and they don't ever get to talk about it or understand how to
Well,
make complaints.
yeah, that's what I was gonna say. It's not reported. And that's what it is. I mean, we need to, I encourage everyone, if you're going through something like this or if you have this experience, report it
Yep,
because
write it,
we,
put it in writing, certified mail, so they can't ignore it, and send it to the chief risk manager, the
Mhm,
CEO of the hospital system,
mhm.
whoever else was in your care team. then they have to respond and send it certified mail.
Yep.
Don't let them hide. Write it and then do the joint commission.
It's worth the fight. You're helping someone else. Like you might have gotten treated like that, but in order to stop this, we're gonna have to report these things.
Exactly.
And it can stop because this is ridiculous.
You think it happened to me, but like you think what happens to Black patients in care all the time? Infant mortality rates. Serena Williams almost dying during birth because they don't want to listen.
Yep.
Venus Williams with fibroids. There are many things that impact us that we often are routinely ignored or dismissed.
Yeah.
In this case, it was not my surgeon. My surgeon and his residents were great. They were advocating, but when you have a hospital system that seems to be dependent on making life miserable, it does not matter. My surgeon was phenomenal. I have no issues with my surgeon at all.
Okay, good. Well, at least you had a good doctor. Some people don't even have that.
Yep.
They don't even have a doctor that cares so much. It's a lot. We talk about these issues very often, and we'll keep talking about them because we must continue to use our voice and share these experiences. But it always is very upsetting, and to know that so many people deal with this. So we're going to keep amplifying our voices on here. Going back to the lung cancer research, and share with us some of the things that you want to see as far as the research in the field. Like, where should we be moving?
We should. This is a good one. You know, contrary to what our government is telling us, we need to have more diversity in the research workforce, in the medical workforce, because there are clear studies that are shown when patients have providers that look like them or have literature, they are a little more relieved because you aren't dealing with ivory towers that ignore you and treat you like you don't exist. The other thing is we did a study with USC where we looked at all the lung cancer cell lines available. I think you might have seen that. I don't remember.
USC,
it was 800 cell lines we found in the literature for lung cancer. Of those cell lines, 390 were Asian, 200 were white, 30 were Black. And this is out of 800 that we know. None were Hispanic, Native American, Alaskan Native, Pacific Islander.
Come on.
And of those lung cancer, only one was from a Black individual for non-small cell lung cancer.
Wow.
So you already know where this means. If this is our starting material, and we develop most of our therapies from tumors that have become xenografts, then to cell lines, we would then test all our therapies, do our biomarker, and then we put them back into models and put them back in humans. If we don't even have materials that reflect these populations, then none of the work we are doing is really going to be impactful. So then this is why you had the study several years ago that showed, well, we have these different immune adverse events in Black patients on post-market analysis. Well, if you just tried to include the people, you might have found them. And most people go run and do trials at the major academic centers. While they have great infrastructure, they still don't really have the needs of best interest of the underserved communities in mind. And then you can't really get past that hurdle.
Yeah.
And so if you don't have people from the community on your outreach and engagement and following up with people and listening, they have different lived experiences. You can't say, oh, well, they didn't make it, they were non-compliant. You do understand if they're working two jobs or they have front-facing jobs where they don't get the luxury of time off, or as I learned on Medicaid, transport, it can help you when you need it, but it is not your friend. Because I will tell you, I had numerous appointments. I tried to get transport, and then you have it scheduled, and then they would just not show up, or they would cancel last minute, and then you're showing up late or not at all, and then you get labeled non-compliant, but it's none of your fault. Or I've had transport, I had 3 ordered to pick me up to take me back home when I still couldn't walk. They didn't show up after an hour. I was like, I'm just gonna, and I was sort of at that point stable-ish enough. But I finally took a bus and I took the bus and then a taxi. I said, I'm not doing this. So you can't, even though you have transport for Medicaid patients, it is very unreliable and they don't have one fixed company. They use multiple cabs and then you never know which one's going to come. And just because they say it doesn't mean they will. So that's the most frustrating thing as well. So as we go back into the research, so we don't have samples that reflect patients. How do you think the trials are ever going to be reflective? And the other thing of our study, we saw that there were about 2.7 to 1, 2.7 to 1, so about 2.7 times more male cell lines than females. But if we looked at the Asian subset, it was 7 to 1. 7 to 1 male to female. So are we even really getting representative stuff at all? And so we really need to think about really engaging the patients at all stages of research, letting them know about trials, really working with them instead of just dictating and helping them understand the importance of research. But also we need to give people agency over their samples so they can get actually compensated for the studies that you do, future studies you do with themselves, but also as we do trials, which is a tricky thing, give people fair compensation for participating in studies. But that's where you get into the FDA guidelines where you can't give too much because then it looks like coercion. So that's the catch-22. But we've also shown stuff where even Black patients that are PhDs and doctors still have bias navigating care for lung cancer, screening and diagnosis compared to their other counterparts, even those that are educated. We had a study that showed that. So it is a broader issue that we still really need to work to address. And so when I was at Longevity, I created the Minority Mentorship and Training Program to try to get the scholars more wraparound support and comprehensive training to navigate not just careers, but career transitions and professional development. And we still at the SHAC can work with orgs to develop mentorship and training programs that are inclusive and comprehensive and holistic. So you think not just about the training, but how are we enabling them to learn about how to navigate their life? So
yeah, that's awesome. And so tell us more about your conference that's coming up, because it is, I was asking this earlier, was it for patients and caregivers? And so who is the conference for? We would definitely share the information in our posts.
Yep. So it is for basically everybody. It is free for patients, caregivers, and survivors. We always make it free for them. Everyone else, it's scaled up in cost. It is an in-person event, and it's going to be at the University of Illinois Cancer Center, October 24th, 25th in Chicago. We have 2 packed days of concurrent sessions. We're talking about, we have a patient panel, a caregiver panel, and a panel on survivorship. We are talking about biomarkers, clinical trials, translational research, community engagement. We have advocates from other cancers talking about what they've done to educate their community about disease. We have a small cell tumor board, which we've never done before. So that's going to be pretty exciting. So we really try to bring different depth and breadth of conversations to really empower people to learn about the disease and what they can do, even when they're not in the rooms. How do you learn about your disease and how you can advocate? So we want the patients to learn more and be empowered. We want the other stakeholders to learn best practices. And we want them to be able to get better at talking to these communities who need the help, and then communities learn who actually is working on their behalf.
I love it because this is so needed in the community. Of course, Chicago is home for me, so I love that you're doing it there. And you do this every year, right? This is an annual event.
Yes. And it's on our website, scheq.org. If you go to the events tab, you'll see a tab for the 3rd Lung Cancer Intervention Summit. You can just go there and register there, or you can just find the same thing, 3rd Lung Cancer Intervention Summit on WHOVA, WHOVA. It's on the WHOVA app as well.
Okay, awesome. So we're going to get out of here, but I want the community to know this conference. If you're in Chicago, if you can fly to Chicago, if you're a patient, if you're a caregiver, if you're anyone that's interested in lung cancer research, this is going to be super impactful, this conference. So we want to definitely, you want to be there. Knowledge is power. You guys hear that all the time, but it is very true. You need that knowledge if you're dealing with any type of health condition, right? And if it's lung cancer, especially with all the inequities that we talked about today, all the injustices that we see in healthcare when it comes to Black and brown people, you need to empower yourself. That's one of our favorite words, Eugene, empower our communities.
Empower. It's great. Don't let anyone else dictate to you. Be in control of your own destiny when you can.
Yep. That's right. Okay, so anything before you want to share before we leave? We're going to get out of here. We thank you so much for your time and your powerful voice today. And we hope that this episode can help someone.
Thank you so much. I'm so happy you invited me today. Just a couple small minor things. If you're interested more about our work, you can visit our website, scheq.org, scheq.org. We have our infographics there under patient resources. They're free for patients, caregivers, and survivors. So you'll find the stuff there. If you're interested, we do run 2 lung cancer webinar series. You'll find information about those on the website. And we do the conference, and I have started a podcast. We haven't aired the first episode, but it's called Microscopes to Moonshots, Real Stories in STEM. So yes,
so
we hope we get the first one aired this month. But really, part of the thing of I don't have bandwidth to do science camps right now. We can help people learn about STEM careers, particularly kids. We want them to learn about different STEM careers that they can go into, because when you're first gen, you don't hear any of these things. So we can get people to talk about their careers and the kids, and then we might be able to light a spark under them to help them engage. And if anyone is interested in volunteering, we have on a website to contact us. We definitely need volunteers to help us as we increase and scale our programs. And we hope next year to start patient meetup groups. We hope.
Okay. So we just need to stay tuned, because you doing a lot and you're on the move, and we are so grateful for you. Thank you so much, Eugene. And everything that Eugene just mentioned, we will make sure we have it in our show notes so you can get that information. Yeah, thank you so much. I appreciate your time.
Thank you so much. Always a pleasure talking to you. All right. Bye-bye.
Bye-bye.